Okay, so yesterday I talked about aortic regurgitation in the setting of truncus. We stressed that aortic regurgitation or truncal valve regurgitation affects outcome. So for this talk on bicuspid aortic valve, even though aortic regurgitation can be an important part of it, I thought to talk about aortic stenosis and talk more about chronic aortic stenosis and borrow a bit from the adult world. By the way, Norman, we showed yesterday those remodeling processes, and just a comment. I think that the eccentric remodeling, concentric remodeling, etc., which is really the mass volume ratio or the phenotype of the mass volume ratio, a lot of emphasis was put on that, and I think it originated from the framing study with blood pressure, and a guy called Gowder continued that work. And a lot of emphasis was put that eccentric remodeling is a bad prognosis and concentric remodeling is maybe a good prognosis. And I've read some literature in aortic stenosis that may not hold true, or perhaps it's true but not as much as people thought. So I'm not sure where that comes, how important it actually is. But anyway, if we just repeat this to kind of get a background for the talk, this is what really the ventricle wants to do. It wants to develop active force, that's in the myocytes, that's its intrinsic contractility, in order to develop pressure within the cavity that will then overcome its afterload and the blood pressure to open up the aortic valve. It then wants to eject blood by deforming the wall faster. So I told you about the strain rate being early and strain developing through and peaking at aortic valve closure. And this is influenced by ventricular geometry. We've talked a lot about that with ventricular dilatation and remodeling, the fiber orientation that I talked about in the first day, as well as other components such as elasticity and the actual afterload. So if you look at a ventricle that has increased afterload because of, let's say, aortic valve stenosis, the ventricle is going to have increased wall stress by virtue of the higher pressure in the cavity, and perhaps even by virtue of cavity dilatation. And in order to compensate for that increased wall stress, because that's not a situation the ventricle likes in terms of its myocardial oxygen consumption and its function, it's going to compensate by hypertrophy. I didn't put up the formula here, but dividing by the wall thickness brings down the wall stress. I should put up that formula. But if you look in the ventricle, the ventricular diameter, which is Laplace's law and is going to determine the wall stress, is not uniform in the ventricle. It's much lower at the apex because the radius of the circle is much lower at the apex, and it's much higher in the basal components because that's where the ventricle, the radius of the ventricle, if you had to imagine it as a circle, is much larger. So when the ventricle hypertrophies, it actually does so not in a uniform way, but in an asymmetric way. And you'll often see this basal bulge getting thicker because it's compensating in those areas where wall stress is actually higher. And not only will it do that, but if you look then at the strain patterns in the different parts of the ventricle, you'll see that this basal septal part over here has decreased deformation and post-systolic shortening as a response. I told you post-systolic shortening is not specific to ischemia. It develops in other conditions as well, and here's an example. So the ventricle, really, I used the example of the world economy, which we discussed at dinner last night, that the world economy is not one, and it's very different when you start looking at different regions of the world. And we are interested in knowing, how Greece and Spain and Italy and Canada are doing, rather than just how the world's doing. And so we're interested in the ventricle, in knowing how different parts are doing. It tells us more about the state of ventricular function. Now, in pediatric data, there's not a huge amount on aortic stenosis and on chronic aortic stenosis. And again, neonatal aortic stenosis is a bit of a different animal altogether. But in chronic aortic stenosis, not that much data. Ben Idem, who studied tissue velocities earlier on a few years ago, did compare different loading conditions on velocities, and these are chronic. You remember chronic versus acute. These are chronic aortic stenosis patients. And you can see that in general, obviously, left ventricular mass is high here, but notice that left ventricular mass in dilated cardiomyopathy is even higher. That's the eccentric remodeling we're talking about versus the concentric remodeling. So it's not only in afterload, in pure afterload, that elevation that the ventricular mass is elevated. I told you that dilated cardiomyopathy also has increased afterload because of the increased wall stress, and this shows it quite nicely. If you look at the actual velocities from these patients, you'll see that they're not that different from control subjects. I want to bring up something which I think is interesting, which the rest of the data actually doesn't show or doesn't support. If you challenge the left ventricle with a mild to moderate degree of stenosis, if you increase its afterload by a mild to moderate degree, you band the aorta, or you create aortic insufficiency, the left ventricle will actually increase its contractility as an adaptive process. If you go severe, you're obviously going to overcome that. But these tissue, I would have expected tissue velocities to be normal or even higher. They're only very mildly reduced. It's statistically significant, but I don't think clinically significant at 9.1 versus 10.5. But nonetheless, they were mildly reduced, but I think this shows that there's chronic adaptation more than anything else. What does hypertrophy itself do to systolic velocities? Well, it probably has a varying effect depending on what your disease is. This is an adult paper. Athletes who hypertrophy, obviously that's a physiologic mechanism. They have normal intrinsic contractility and they have good normal velocities or even elevated velocities. If you take hypertension or hypertrophic cardiomyopathy, you have low velocities, as I showed you beforehand. Now let's talk a bit about strain. Again, hardly any data in kids in aortic stenosis. This is actually an M-mode study if you're looking to do M-mode. As far as I could ascertain, they only used M-mode for deformation. Maybe I'm wrong, but they report the deformation. This is from Nijmegen and from Hungary. And you can see that they use the thickening from the M-mode on the wall to look at strain rate. If you think of thickening of a wall, that's strain. You can do it from M-mode. And if you look at the rate of that thickening by the slope, and you can now think of slope as slippery slopes, because Girish told you that you can't measure slopes. But in this research study they did, and that was systole and diastole. So nonetheless, whatever method they used, you can see that in these patients, both tissue velocities and strain were actually quite reduced in patients versus controls. And this is radial, because you saw that it was taken in the radial direction. So this is a bit against what that phenomenon of left ventricular adaptation that I was talking about. The mean gradient here was 43, and I searched hard for the mean gradient in the paper, and I put it up here because it does depend on how severe your aortic stenosis is, and I'm going to show you that, and that's quite important. As I said to you, diseases aren't only of systole or diastole, they almost always involve both, and you can see that the diastolic deceleration time from those M-mode slopes was also quite abnormal. So with this hypertrophy, the patients also have delayed relaxation, which is going to affect their diastolic filling. Now, this is adult work from Toronto General across the road, and all the work I'm going to show you from now on is probably in adults, bar maybe one study or so. But if you look at aortic stenosis, it's an interesting disease, because the heart is built, as I think Karen told you the first day, or I told you, that they're longitudinal fibers, and the fibers that then change their orientation to a more diagonal orientation, and the circumferential fibers. And the subendocardial fibers are mainly longitudinal fibers in the left ventricle. And those are the fibers that create that initial force generation that's going to open up the aortic valve. And then you get the radial fiber, the circumferential fibers, holding that ejection and creating the deformation. I've simplified it, but just in big terms. So if you look at aortic valve area here as a measurement of the severity, an index of the severity of the aortic stenosis, and just look at circumferential versus longitudinal strain pre-aortic valve repair, usually circumferential and longitudinal strain in their absolute values are quite similar. Longitudinal strain's a bit more, but they're quite similar. You can see that preferentially longitudinal strain is affected more than circumferential strain. And this is an important message that's going to go through the talk, because when you're evaluating the severity of aortic stenosis and you're looking at myocardial deformation, you want to look at longitudinal parameters, because it's those fibers that are predominantly and also temporally in the severity of the disease and in the course of the disease are going to be affected. And so here's a study that actually shows LV hypertensive patients and AS patients in terms of radial strain are also affected, but you can see it doesn't reach significance, and you can see that circumferential strain and especially longitudinal strain, if you look at the differences here, are much more affected in AS patients. Now, one of the important things that happens in aortic stenosis, when the severity of the stenosis increases and there's increasing wall stress and the hypertrophy is inadequate, or perhaps the blood supply is inadequate to keep up with the wall stress and the hypertrophy, is you start to get areas of fibrosis, which I'm sure Dr. Hasbani is going to show you by MRI, but here's an example in an adult patient of 78 years old. And you can see that the aortic gradient isn't that high. It's a mean of 28 if you're judging in pediatric terms. The adults wouldn't use this. But you can see that the mitral ring displacement, which is in essence the MAPC, we talked about TAPC with M mode looking at tricuspid valve displacement. You can do the same on the mitral valve and look at the annular ring displacement very simply by M mode. You can see that it's only 6 millimeters, which is markedly decreased. And that index has proven to be very, very useful in modern studies by groups who do a lot of strain imaging, because it reflects very nicely that longitudinal dysfunction of the left ventricle in aortic stenosis. So if you look, first of all, here at the histology score, the fibrosis score, and you look at just the mitral ring displacement, you can see in general that when you have less fibrosis, your ring motion is higher than when you have more fibrosis. But the group that this may help most with are those patients who have a low gradient, as I showed you before, a relatively low gradient, and they have a preserved EF. Those are patients that you don't know what to do with, or you wouldn't send straight away for intervention. But if you look at their mitral ring displacement, their function is already decreased. And if you have to use the correlation with fibrosis, those patients have probably started having quite significant fibrosis. And again, you want to catch the ventricle at a stage where there's still reversible dysfunction. So I think that these parameters may be quite important when ejection fraction is still preserved. So fibrosis does have a large impact. And if you have no fibrosis, mild fibrosis, or severe fibrosis, it's going to impact your wall stress. As I showed you, it will impact the mitral ring displacement, and it will impact your strain, especially your longitudinal strain as well. And look at this just aggregate stepwise decrease. As your fibrosis increases, your strain decreases. It's not surprising, but there's a clinical parameter to help you along. And just in terms of what we expect after aortic valve replacement in these patients, if you had no fibrosis, these patients maintained normal strain after aortic valve replacement. And if you had mild or severe fibrosis, then you had less recovery, especially if you had severe fibrosis. Your strain improved but did not normalize. And so this is the message. You want to catch them early, and we need echo indices to judge before ejection fraction worsens when you're going to catch this ventricular dysfunction. So look at the longitudinal parameters, whether they be simple M mode parameters or longitudinal strain. And here's M mode, and I showed you a lot of Frank Wiedemann's work. He knows strain and tissue Doppler extremely well, and what worked out well for him was mitral ring displacement. And you can see how it correlates with the degree of fibrosis quite nicely in this article. And this is just to summarize that it correlates. And it correlated with late gadolinium enhancement on MRI as well. As I said to you, the abnormalities are not only systolic, they are diastolic as well. You can use Doppler of inflows and tissue Doppler to show that. And if you look at the E to E prime ratio, which we said is an index of filling pressures and diastolic function, you'll see that in patients with aortic stenosis, they have markedly increased E to E prime ratios, which reflect, I think, as well, part of that fibrotic process and the increased afterload with increased end diastolic parameters. Now, one of the things that is affected in aortic stenosis is this concept of left ventricular torsion, which we've talked in different talks about, where the apex rotates in a clockwise direction, the base in a counterclockwise direction, and you get a torsional motion. Now, if you look at torsion in aortic stenosis, it's actually quite surprising, because intuitively, if I said to you, what's the torsion in aortic stenosis, the first answer that would jump out is that it's decreased. But it's not. It's actually increased. And I think there are two reasons for that. The main reason that it's increased is because you have decreased the function of those longitudinal subendocardial fibers, leaving the subepicardial fibers unopposed. So you're actually increasing the torsional change in systole. I think also that part of it may be that adaptive mechanism I'm talking about. But what you see actually, and here's the data, here is increased twist. Twist and torsion are similar, just one is corrected for length. So you have more apical rotation, you have the same basal rotation because of those subendocardial fibers being decreased in their strain and increased twist overall. But what is decreased is your diastolic untwisting. So again, your systolic twisting then influences your diastolic untwisting and filling. I already showed you that these patients have decreased or delayed filling, and one of the mechanisms is because there's delayed untwisting velocities. When you replace the aortic valve, things do improve. Strain gets better or normalizes in some segments, but not in all segments, and you want to catch those segments at an earlier stage. But you can see that circumferential strain actually decreases over here. Longitudinal strain, as I showed you, increases. So it does depend how you're measuring these things, and the ventricle works differently in afterload, in increased afterload. I'm just going to skip this because of time interest. It's showing similar things, and again, similar things in terms of recovery of strain. And I just brought a couple of examples using vector velocity imaging, which is speckle tracking, to show LV function. You can see by eyeballing this ventricle that LV function isn't normal. Even though that this is at a mid-ventricular level, you can still imagine that the twist here is increased. And if I play the strain curves, you can see quite an abnormal pattern of contraction with the septum going the opposite way to the posterior wall. And if you look at the circumferential strain curves, this isn't shown by those arrows because you'd be looking in this direction. It's decreased strain, even though the patterns here look relatively normal. The radial strain is abnormal, but I'm not sure that those curves are reflective. So if I just move on to another patient with AS and so-called good function, here again you can see, I'll just play, this one probably doesn't play, sorry, let me just go back one. With good function, because I wanted to show you those longitudinal strain curves down here, you can see that there are segments that are abnormal, even though looking at this ventricle, it looks like it has good function. And here's the circumferential strain curves, which are actually increased in this patient. So I showed you increased circumferential strain, decreased longitudinal strain, and this is just from a patient. And this is where we should be this afternoon, but we're not going to be. Okay, so thank you very much for your attention.